Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. Today, I have the great pleasure of speaking with Dr. Oliver Klein, who is at the Olivia Newton-John Cancer Research Institute and also in Austin Health in Melbourne, Australia. And the reason for this podcast is we're going to discuss a recently published, very important article in JAMA Oncology titled Nivolumab and Ipilimumab Combination Treatment in Advanced Ovarian and Endometrial Clear Cell Cancers, a non-randomized clinical trial. Really excited to talk to you, Oliver, about this article. Congratulations, of course, on the JAMA Oncology publication. Congratulations to all of your co-authors. So very excited to have this discussion with you today. And again, welcome and thank you for accepting our invitation and for speaking to us from Melbourne, Australia.
Thanks, Pedro. It's a pleasure to participate. Yeah.
Excellent. So, Oliver, as you know, we have lots of questions, and we wanted to start by discussing a bit about clear cell carcinoma of the ovary, and then certainly again of endometrial cancers, and specifically talk about the genomic profile of these cancers.
Yeah, thanks, Pedro. I mean, I believe it may be well known to the listeners, but as you know, gynecological clear cell cancers are rare subtypes. Also, if we talk about ovarian clear cell cancers, it's in the Western population, it's between 5 and 10% of the incidence of epithelial ovarian cancers. But if we look here closer in Australia to our Asian neighbors, for example, in Taiwan, Singapore, Japan, China, it's actually a significant proportion of epithelial ovarian cancer. So these days it's between 20 and 25% of ovarian cancers in these countries. So it's not really a uncommon disease here in the Asian region. They have some kind of specific features in terms of clinical features. We know they have a higher risk in advanced disease for thromboembolic events, for perineoplastic hypercalcemia. There's obviously this observation, which is well studied, that ovarian clear cell cancers are associated with endometriosis in 50 to 75% of cases. It's varying in terms of the descriptions. And as you pointed out, they have a quite unique genomic profile compared to high-grade serous ovarian cancer, for example. So in roughly 50% of patients, which we have seen in our study as well on the genomic analysis, carry a mutation in ARID1A, which is a gene that encodes for a protein that contributes to a chromatin remodeling complex. We also see 50% roughly half of the patient population mutations in PIK3CA mutations, which is obviously of interest, particularly given that this is potentially now targetable with oral inhibitors, as we see already in breast cancer. And if we look to other genomic markers, BRCA1 and BRCA2 is obviously much less common than in high-grade serous ovarian cancer. However, what is something more enriched is microsatellite instability, so mismatch repair protein deficiency, which is obviously something which predicts for treatment response to immunotherapy. I should point out in our study, there were 2 out of the 24 patients with ovarian clear cell cancers that have been microsatellite unstable. Yeah. So yeah, it's a quite unique patient population.
Yeah. So tell us a little bit about like the rationale for immunotherapy and how this may be of benefit to these patients in the setting.
Yeah. Thanks, Pedro. Yeah, there were early trials or many years ago now, trials in epithelial ovarian cancer and recurrent epithelial ovarian cancer studying anti-PD-1 agents. So a well-known trial is the Keynote study. I think it was Keynote 100. A very large phase 2 study investigating pembrolizumab, an anti-PD-1 antibody in epithelial ovarian cancer, and that's shown fairly disappointing results, well below 10% objective response rates. And in some of these, or in most of these studies, it was really a signal that the subtype of clear cell ovarian cancer may derive a greater benefit. So, for example, in Keynote, I think there were 15 or 20 patients with clear cell carcinoma, and they had an objective response rate from 15%, which compares to the, I think, 5 or 6% in the overall study population. I mean, there was certainly there were some indicators. We have actually based the MoST-CIRCUIT study on a previous trial, which we run several years earlier. So I think we started enrollment to a rare cancer trial back in 2017 that had a dedicated rare gynecological cancer cohort, which that included roughly 45 patients, 50 patients. And there were also 8 patients with gynecological clear cell cancers, and 3 out of these 8 had very prolonged responses. In fact, 2 are still in complete remission since 2018. So that provided the basis then for the MoST-CIRCUIT trial, or for this cohort of the MoST-CIRCUIT trial. Yeah.
Excellent.
So
So now, this trial, of course, known as the MoST-CIRCUIT trial, what was the design of this study? And can you also speak about the eligibility criteria and the treatment regimen in this trial?
yeah, thanks, Peter. Yeah, so it's MoST-CIRCUIT is actually a multi-basket trial. So it's more than this 28 patients of gynecological clear cell cancer. So it was a four baskets. It's actually 240 patients who had been enrolled into this study. Once again, it based on this previous trial, which was called CA29538. Oh my God, too many numbers. But and so MoST-CIRCUIT pretty much took forward selected rare cancers, including gynecological cancers that have shown where the previous study has shown activity. And one pre-specified subgroup in the gynecological cohort had been patients with gynecological clear cell cancers, hence the enrollment of these 28 patients. The key inclusion criteria, I mean, it's so the standard immunotherapy patient inclusion. So obviously autoimmunity was excluded, other than very mild, like vitiligo or well-controlled autoimmune conditions. We just for this study allowed 1 line of prior therapy, which had been a kind of learning from the previous study, where often heavily pre-treated patients were enrolled onto the trial and unfortunately dropped out quite early. So there was a dropout rate in the overall study population from 20-25% of patients. So we wanted to prevent that with that. So that's for the limitation of the trial. So they could be treatment naive or 1 line of treatment. And we've chosen, what we believe is a immunotherapy treatment that strikes a good benefit between having a high efficacy and manageable toxicity. So as you may know, combination anti-PD-1, CTLA-4 combination therapy, at least in some malignancies, is superior to anti-PD-1, PD-L1 monotherapy. However, which is interesting, is really that the dosing of the CTLA-4 antibody ipilimumab that pretty much decides efficacy and toxicity. And with the 1 milligram dosing, you generally get a third of patients with severe immune-related adverse events. So that was the rationale for this treatment regimen, pretty much based on the previous trial as well, which used the same treatment regimen as the one studied in MoST-CIRCUIT. Yeah.
Great. And can we talk then about what were the primary and secondary endpoints of the trial?
Yeah. So the primary endpoints, there were 2 co-primary endpoints, was objective response rate according to RECIST, and 6 months progression-free survival, which we've chosen at the time. So that this trial was designed a few years ago, as there were emerging evidence that 6 months PFS is actually a good surrogate for overall survival in pure immunotherapy trials. It's not very good in immunochemotherapy trials like lung cancer or other malignancies where you use checkpoint inhibitors with chemotherapy, but in pure IO trials, as in ours, 6 months PFS seemed to be a good surrogate for overall survival. So that were the 2 primary endpoints. Secondary endpoints were the median OS, the median PFS, and also treatment-related toxicity. Yeah.
So now getting on to the results, Oliver, 17, I believe, Australian and New Zealand sites, and a total of 28 patients, 24 with clear cell of the ovary, 4 of clear cell of the endometrium. What were the results that you find, and then what are some of the highlights that our audience should take away from this study?
Yeah, so it was, I mean, it was really exciting to see. I mean, we had this indication already from the previous study and obviously from the epithelial ovarian cancer studies, the subgroup analysis that anti-PD-1 based checkpoint inhibition can be effective. And we saw really in every second patient an objective response. And I mean, as we would expect with these treatment regimens, often these responses were very durable. So we haven't, on the last data analysis, we haven't reached really the median OS. The median PFS was close to a year. As I said, objective response rate in the overall study population was 54%. I mean, obviously, always acknowledging that this is a small cohort of patients, but we were really excited to see how many patients responded to this treatment. And immune-related toxicity with a third of patients developing high-grade immune-related adverse events was something we expected with the regimen, which is in keeping with what's described in the literature with other malignancies using the same treatment regimen. Yeah.
Great. So now let's get on to some of the questions from our fellows. And this first question comes from Lebanon Rim Abu Chakra, and she's asking, the trial included patients without prior systemic therapy or those who had only one prior line of systemic therapy. Was this mainly to minimize heavily pretreated, immune-exhausted tumors or assure enough fit patients for combination therapy?
Yeah, thank you. Yeah, as I previously alluded to in our previous study, obviously we had no restrictions of line of therapy, and the observation had been that a fairly large number of patients did not make it to complete the induction treatment. And I mean, we can speculate. I suspect certainly immunotherapy and checkpoint inhibition is best used in earlier lines of treatment, particularly in fairly aggressive or fast progressing cancers. I mean, recurrent or persistent ovarian clear cell cancer can be a very, very aggressive malignancy. Hence, that's why we limited the line of treatment. And most likely increasing tumor burden, I mean, we know this from other malignancies, can cause some kind of immunosuppression, most likely by increasing myeloid suppressor cells or increasing immunosuppressive immune cells like Tregs. So I personally believe these kind of regimens are best tested in earlier line of treatment and later lines of treatment. Yeah.
Excellent. So Frederique Stroich from Heidelberg University in Germany, she's asking, among the patients who achieve partial or complete response to the combination of Ipi/Nivo, how many completed the full induction phase, and were responses observed only in patients who received all 4 doses of combination therapy, or did some respond after fewer cycles?
Yeah, so there were a few patients. So I look back in the data set because we haven't reported on that in the manuscript per se, but 3/4 of the responders, so 9 out of 12 or 9 out of 13, have actually completed the whole induction treatment. So 1/4 of patients came off, some after 2 treatment doses for high-grade immune-related adverse events, but these patients still have obtained responses. And the responses are, I mean, it's a very small number, or fairly small number of patients, but they still responded in the same way as the patients who completed the induction treatment. And I think that's also where, if we take lessons from other malignancies using the similar treatment regimen, so this kind of induction regimen, we know there were some trials done with US colleagues in melanoma who used pretty much just 2 doses and compared it to 4 doses. And it seemed like that's what sometimes is all needed to initiate a very effective anti-tumor immune response. Yeah. So you don't need really all 4 completion induction treatments. Yeah.
Excellent. So this question comes from Mariana Carvalho in Sao Paulo, and she's asking about biomarkers. Did you study or explore PD-L1 expression as a potential biomarker of response?
Yeah, we're in the process. So we obviously did some exploratory biomarker analysis, which is part of the manuscript as well. But we're in the process actually with some international collaborators to acquire larger data sets in terms of patients who are treated with PD-1 inhibition and test. We specifically didn't do any PD-L1 testing. We've done that in the first trial, not just in clear cell cancers, and it wasn't very helpful. So there's also the idea. I mean, obviously, PD-L1 is generally a surrogate for a hot tumor microenvironment. So there are TILs in tumor-infiltrating lymphocytes. They generally express some gamma interferon that upregulates class 1, but it also upregulates PD-L1. So it's really a surrogate for a hot tumor. I know from some of the studies, for example, the Peacock trial in gynecological clear cell cancers that was published earlier this year with pembrolizumab, used PD-L1 staining and didn't show any kind of discrimination between responders and non-responders. And I mean, there's explanations as well. It could just be it's a heterogeneous expression, so it depends when you obtain the biopsy and from what area you obtain the biopsy. No, we haven't done any PD-L1 yet on this patient population, but we are intending to do so. Yeah.
Very well. So Natalia Tejeda from Hospital Clinic of Barcelona in Spain, interested in ARID1A question, and she's asking, despite previous evidence linking ARID1A loss to increase immunogenicity and responsiveness to checkpoint inhibitors, your study found that response occurred in both wild-type and variant ARID1A tumors. How would you explain this unexpected result, and what implications do you think it might have for the use of ARID1A as a predictive biomarker in clear cell gynecologic cancers?
Thanks. Yes, no, it's a very good question. We were surprised as well because I mean, as some of your listeners may know, ARID1A, obviously, we talked about it's a very common genetic aberration in gynecological clear cell cancers. There's quite a bit of preclinical evidence that it can increase immunogenicity in the degree of DNA instability, but there was, in fact, just recently a fairly high-profile publication in Cell showing that it can activate innate immune pathways. So you get kind of these gamma interferon signatures in tumors that wasn't just specified in gynecological clear cell cancers. And then there was some translational research, which we've also cited in our discussion, showing already a few years ago that if you have ARID1A protein loss in histology specimens of gynecological clear cells, you have less TILs. There were conflicting data, conflicting manuscripts. I mean, I don't think ARID1A, at least as it stands at the moment, is not a biomarker for treatment response. How can I explain? May it be? I think most likely we would have to look a little bit on the functionality, on the functional impact of these mutations, because these mutations were not all in the same part of the gene. So some may not carry the same significance than other mutations. We haven't done any staining for the encoding protein, which would be something to do as well on the actual histology specimen. So I can't say that every mutation, also it's described as a pathogenic mutation, is in keeping with protein loss, which then leads to this potential more immune active tumors. Yeah.
Now, continuing on the topic of biomarkers, Luisa Prope from University Hospital Münster, Germany, she's asking, given the limitations you observe with the current biomarkers like ARID1A variants and tumor mutational burden for predicting response to immunotherapy, are there particular avenues of biomarker research or clinical assessment that you believe hold the most promise for the future?
I mean, I guess it follows on what I just said to the previous questioner. It's really, I mean, it's work in progress at the moment. So we plan to do some, not just with this cohort, because the patient cohort is just not big enough, but also with some other collaborators to see if we can address some of the potential subtypes. So your listeners may know there's some gene expression studies performed a few years ago as well from a Singaporean group, from a Chinese group. So particularly in the Asian population, they could demonstrate that there are molecular subtypes based on gene expression profiling. Some of the subtypes are enriched by immune markers, so we can call them immune subtype and non-immune subtype. They had different names for these subtypes, but that's certainly something to look in. And something which I think is sometimes overlooked in terms of we're very centric to obviously tumor biomarkers, but I guess an appreciation which we get more and more, and we've published recently a few years ago on this with our first studies, that there's obviously other factors that really influence treatment response to checkpoint inhibition. One very hot topic is the microbiome. We've shown this with our previous trial that actually microbial signatures are the highest predictor for response. There's emerging evidence that even host germline variations can influence the immune response. We had just a very nice paper in Nature Medicine in melanoma showing that the CMV's serostatus, so obviously 50% of the population is CMV positive and has an immunity against CMV, can contribute or influence the response to checkpoint blockade. And something which is obviously further emerging as well, which comes back to the microbiome, is that antibiotic use can influence in responses to checkpoint inhibition. Even the timing of the day where you infuse the medication. So there's this whole research area of circuitry and immunology as well. So it's I definitely think hopefully we can drill down better on the responders in terms of the tumor, but there may be some other factors which we can't really address very well. Yeah.
Yeah, so really interesting what we learned from other tumors, and
Yeah.
very important, and leads to this next question from Filippo Capomacchia from Candiolo in Italy. And he's asking, all patients enrolled in the trial underwent tumor genomic profiling. According to your results, only TERT promoter mutations appear to correlate with response to treatment. Based on the existing literature on the use of immune checkpoint inhibitors in non-gynecologic clear cell carcinomas, are there other potential predictive biomarkers of response to immunotherapy?
Yeah, that's an excellent question. So there's obviously this kind of overlap between gynecological clear cell cancers and renal clear cell carcinoma, which is it's a pretty common tumor. It's obviously ipi/nivo is a well-established treatment regimen in these patients, and well, there are certainly learning lessons to be have from biomarker research that's done in renal clear cell carcinoma of the kidney. There's, for example, very much interest and predictive potential of what we call TLS, so tertiary lymphoid structures. So you have in your tumor itself little lymphoid organs where particular B cells play a good role. And what I could see from, I think, one of the last ESCO presentations in one of the gynae-onc posters, there was also a small study, I think, from a trial that used a PD-1 inhibitor with, I think, a lag inhibitor. Also showing that TLSs may be a predictive factor for response to checkpoint blockade in gynecological clear cell cancers. Yeah, no, it's definitely a very good idea to get some pretty much instructions from research in renal cell carcinoma. Yeah.
Excellent. So now, Oliver, we're going to get into toxicity and a few questions on that. Another question from Saint Filippo Capomacchia. He's asking, the incidence of immune-related adverse events was 78% in this study. In your opinion, does a combination of anti-PD-1 and anti-CTLA-4 increase the incidence of such adverse events compared to just PD-1, PD-L1 monotherapy?
It does. It's well established, obviously, that combination checkpoint blockade, particularly with CTLA-4 PD-1 blockade, is causing more immune-related toxicity than just anti-PD-1, PD-L1 monotherapy as well. But I mean, at least in some tumors, and I believe as well we can say that actually based on the American the BRUOG data which you may be aware, which was another ipi/nivo trial in gynecological clear cell cancers. They compared ipi/nivo to nivo. It's shown a higher response rate and a better PFS. But I just want to point out, I mean, it's a fairly large number, but we always have to be aware low-grade immune-related adverse events. That's often mild dermatitis. That's a little bit of rash. That's mild arthralgia. So they're generally side effects which are really well manageable. I think what it's really coming down to is really the high-grade immune-related toxicity. Yeah, that's where nearly a third of patients, as expected, developed high-grade immune-related toxicity. Yeah.
So this question comes from Sofia Beigardi in Padua University in Italy. In your trial, nearly 1/3 of patients experienced grade 3 or higher immune-related toxicities, including one fatal myocarditis. Given the compelling efficacy results, how should clinicians balance the potential for durable benefit with the risk of serious adverse events? Do you see a role for closer monitoring, earlier intervention, or more selective patient eligibility in this setting?
Yeah, I mean, as expected, a third of patients develop this high-grade immune-related toxicity. I think we have really well-established guidelines, obviously, for this. I mean, these drugs are around for a fairly long time now. So I think there's I mean, ESCO guidelines, there's ESMO guidelines, there's guidelines from from the immunotherapy societies, how to manage the side effects. I still think on balance, given what we can see from some of the Ipi/Nivo trials, also in gynecological clear cell cancers, the increased toxicity is worth to take the risk for because the efficacy is just superior compared to anti-PD-1 monotherapy. It's really unfortunate, and I have to point out all these high-grade immune-related adverse events, being it hepatitis, being it colitis, has been well manageable. The patient with myocarditis, for example, it's really tragic. That's obviously what's an extremely rare side effect as encephalitis or aplastic anemia. If we look in the databases, I mean, it's well then less than 1%. It's most likely 0.01% of patients who are treated with these agents. But I think the questioner has really a good point. I mean, if we introduce these agents in treating physicians in communities who are not melanoma oncologists, who are not renal oncologists, who aren't used to use these medications, I guess there's caution needed and just education as well, and to say that that we apply and really stick to the monitoring guidelines, which are well established for these agents. Yeah.
This next question is on toxicity and prior treatment, and they ask, did the incidence or severity of immune-related toxicity differ between patients who had not received treatment and those who had already received treatment?
We haven't actually looked in this data. I mean, I don't have this data, so we have to say all the patients who have been pre-treated received cytotoxic chemotherapy. So none of them had prior checkpoint inhibition. I mean, despite the fact that we allowed enrollment of patients with anti-PD-1, PD-L1 monotherapy, none of the 28 gynecological clear cell cancers had any prior immunotherapy. So I think it's extremely unlikely that there was any difference in terms of immune toxicity, with prior chemotherapy,
This next question is from your end of the world, Helena Obermeyer from Sydney, Australia. She's asking, with some trials exploring single agent immunotherapy and circuit testing a combination immunotherapy approach, how do you weigh the potential added benefit of multi-agent therapy against the risk of increased toxicity?
Yeah, I think it comes back from the discussion we had just before. I mean, my personal opinion is, I mean, if we look in the it's very hard because all these data sets are fairly small, including our data set. But if we look in the data sets we have now from the combined trials with PD-L1 CTLA-4 versus the anti-PD-1 monotherapy arm from the BR-UOG trial, or the subgroup analysis from some of the epithelial ovarian cancer trials, we can see the ballpark for anti-PD-1 monotherapy in gynecological clear cell cancers is roughly 15%. Yeah. And it seems like you at least double that with combined checkpoint blockade to 30%, mid-30s perhaps. And you have to balance that against doubling the risk for immune toxicity. I mean, if we talk about monotherapy, it's roughly 15% with anti-PD-1 monotherapy, severe immune-related adverse events. And that's just getting doubled with Ipi/Nivo. So you double your response rate, you double your toxicity. I guess it warrants a discussion with the patient, but I think I still believe that combination treatment approaches is the way to go in this patient population. Yeah.
Great. So great lead into the next question, and with regards to which combination. The question is, your trial showed impressive results for Ipi/Nivo in clear cell gynecologic cancers. However, early phase 2 data with PD-1 plus anti-angiogenic combinations like pembrolizumab and lenvatinib also look promising in this setting, though not yet standard. So how do you see these two strategies comparing if both are validated in larger trials?
Yeah, it's also an excellent question. Correct. So it's I don't know yet, I have to say, but so I think the last 1 or 2 years really brought to light in this kind of early phase trials, all trials it's between 20 and 40 patients enrollment, that really anti-PD-1 based treatments, combination treatments are very effective. So we have this CTLA-4 PD-1 approach, which obtains response rates between 30 and 50% in patients, and then you have the mentioned pembrolizumab lenvatinib data that were just presented again on ESCO, but then also we had a I think, a Lancet Oncology publication last year from a Chinese group that investigated bevacizumab with an anti-PD-1 antibody in clear cell cancers, showed also a response rate of 40%. So once again, we mirror what we can see in renal clear cell carcinoma, where these treatment regimens are standing side by side in the treatment paradigm. So if I would have to pick in terms of durability, I still think dual checkpoint blockade is superior. Would be interesting, which I haven't done, to look in the long-term follow-up from the renal clear cell trials where these numbers sit at the moment. I mean, Ipi/Nivo was trialed there 5-6 years ago. The same with pembrolizumab in large trials. Yeah, I think what raises the question, however, given that there's not really overlapping toxicity. I think with lenvatinib it's more difficult, obviously, because it's not just a pure VEGF inhibitor. It has other toxicities, but particular bevacizumab is obviously a reasonably benign agent, and we know we can combine it with checkpoint blockade. What happens if you do triple therapy? I mean, you could do PD-1, CTLA-4, and VEGF inhibition. And in fact, you may know there's some early phase data now with tri-specific antibodies. So they really block all three pathways. And it would be interesting to see. I think that's something for future trials to see if that can lift up this efficacy signals even further. Yeah.
So this next question is regarding future trials. Mariana Carvalho from Sao Paulo, and you talked a little bit about the incidence of clear cell in the Asian population, but she's asking, do you believe a phase 3 trial is feasible to validate these findings, or could the current evidence already justify the incorporation of Ipi/Nivo into practice, given the rarity of this tumor?
Yeah, that's also a very good question. I think it's very... I mean, from my knowledge, I mean, there was just one successful phase 3 study in gynecological and ovarian clear cell cancers from the Japanese trials group, a country that obviously has a high incidence of clear cell cancers. But I think it would be very challenging to do randomized trials. I mean, I think smaller randomized phase 2 trials with an international collaborative is feasible. I mean, obviously the DOVE trial that compares now an anti-PD-1 antibody to dostarlimab compared to dostarlimab and bevacizumab compared to chemotherapy is a good example of that. I mean, I've forgotten what the trial intends to recruit, but 200-300 patients, I believe. I feel, based on the evidence we have so far from these several, it's not just the MoST-CIRCUIT, from these other studies, is that if funding is possible, that it is a treatment avenue for these patients. Yeah. Do I think that we need really a randomized trial against? I think it's a very controversial topic in terms of platinum chemotherapy. I think particularly in the patients with persistent recurrent clear cell cancer, this disease is so poorly chemotherapy sensitive that I'm not really sure if that's the right comparator. So I would argue, if you do a phase 2 study randomized, you would want to compare a dual checkpoint blockade versus PD-1 and a VEGF inhibitor. Yeah, I think that would be a nice trial to do.
So Oliver, this question comes from Arthur Shu here at Houston Methodist, and he says this is the third trial looking into the combination of Ipi/Nivo. BRUAC 354 showed the combination was better than Nivo alone. The DART trial showed a much lower overall response rate of about 21%. What do you think is the reason that the MoST-CIRCUIT had the highest response rate overall?
I think it's the small numbers. I mean, do I think there's 2 points? I mean, they're all small trials. I think BRUG had 40 patients. The DART trial, so the 19 or 21% response rate. I've actually looked in the abstract, and it was presented, I think, 2 or 3 years ago at ICCR. It's unfortunately not published yet, or I hope it will be published at a certain stage. If you actually exclude, if you really focus on the ovarian clear cell cancers and also include what they haven't rightly done in their abstract, in their conference presentation, if you include the unconfirmed responses as well, you actually come to pretty much the same number as the BRUG group. So mid-30s, 30. I think that's where the ballpark is. I mean, the 55%, if you enroll another 20 patients, you will most likely get a drop of your response rate to 40%. I still believe on the induction. So what the big difference between the two previous mentioned trials and our trial is the administration of ipilimumab. And that's really a whole podcast, I guess, at the end of the day. But it's really, both trials used an ongoing flip dosing IP regimen, so a low dose of ipilimumab just given every 6 weeks for 2 years. And I think that's a regimen which is approved in some malignancies, but I think it's inferior to the induction treatment. But it's not inferior by 20%. Yeah. So I think where we're landing is pretty similar to the other studies in the mid-30s. Yeah. But I still think it's a significant benefit, particularly in view of the durability of these responses often in patients. Yeah.
Well, Oliver, as a new tradition now in the podcast, the last question is a question that was developed by AI when AI was given your article to review. So the AI question is, given the non-randomized design and small sample size, are we at risk of over-interpreting the high response rates, mistaking early signals for definitive efficacy in a population with historically dismal outcomes?
Okay. I guess it comes back what I just said. I mean, I don't claim that we have a response rate of, I mean, we have a response rate of 54% or 55%, but I guess we have to put that in a bigger picture. It's a small trial. We know the other studies. It will be lower than that. If you study 100, 200 patients, you will not end up with 55% response rate. Yeah. So it's, yeah. But
Well,
I think it's a really promising treatment approach in these patients. Yeah.
it's exciting, definitely,
Yeah.
and I'm really glad that obviously this study was done and what it offers. And I want to say again, thank you very, very much for accepting our invitation. Congratulations once again to you and the co-authors in putting this together. Thank you.
Thanks, Pedro. It was a pleasure to participate. Thank you.